In physics, there is this famous concept called the observer effect.
Oh, right, where measuring something actually changes it.
Exactly. Like, the basic idea is that the very act of trying to observe a system fundamentally alters the thing you're looking at. You shine a light on an electron to figure out its position, and the energy from that light physically bumps the electron off its path.
Right, so the measurement itself basically becomes an intervention. I
Yeah.
mean, we can never truly know the completely undisturbed state of that system.
Yeah, and we accept that in quantum physics, but we somehow expect biology, and specifically clinical medicine, to be totally different.
Which is wild when you think about it.
It is. You go to the doctor, they draw your blood, and you just assume that tube of red liquid is this perfect, objective snapshot of your internal health. It's supposed to be, the undisputed truth.
Yeah, well, the reality of hematology kind of shatters that perfect snapshot. When you look closely at how blood platelets behave, we are dealing with a biological observer effect that is just incredibly profound.
And honestly, it's a little unnerving once you realize how it works because, we're relying on these blood samples to make life or death clinical decisions.
Absolutely.
But what if the very act of drawing the blood, even just the psychological anxiety of sitting in the waiting room anticipating the needle, is actively altering the cellular results before the doctor even looks at them?
That is exactly what happens.
And that is our mission for this deep dive. We are digging into a fascinating stack of medical guidelines, hematology research, and physiological studies to answer one very specific question for you listening. What is the effect of acute stress, like high cortisol, or the physical trauma of a blood draw on circulating platelet activation markers?
To really understand the stakes here, you have to look at the unique nature of platelets themselves, because they aren't just passive bricks floating in the bloodstream.
Right, they're active.
Highly active. They are enucleate cell fragments, meaning they don't have a nucleus, and their entire biological purpose is rapid response. They are these wildly reactive first responders constantly sampling their microenvironment.
Like little cellular tripwires.
Exactly. They are packed with chemical granules, just, waiting for the slightest mechanical or chemical excuse to activate, change shape, and stick together to form a clock.
Okay, so before we even step foot in the clinic for the actual puncture, we need to establish the biological baseline. Why does your mental stress, like the psychological anxiety happening up in your brain, change the physical behavior of these cell fragments circulating in your arm?
Well, it really comes down to the body's ancient survival mechanisms misinterpreting the modern environment.
How so?
So when you experience psychological stress, like the sheer anticipation of a venipuncture, your brain activates the sympathetic nervous system and the ADPA axis, the hypothalamic pituitary adrenal axis.
Okay.
And your adrenal glands just flood the system with catecholamines, primarily adrenaline, as well as the stress hormone cortisol.
Okay, let's unpack this. It's like the body thinks the stress of a clinical needle might actually be a tiger attack, so it preemptively arms the platelets to stop potential bleeding from a wound that hasn't even happened yet.
That is a perfect analogy, yeah. And the mechanics of how the body arms them are just fascinating. Let's start with the adrenaline.
Right.
Platelets have these alpha-2 adrenergic receptors embedded directly in their surface membrane. When the adrenaline in your bloodstream binds to these receptors, it triggers a drop in cyclic AMP inside the platelet.
And what does cyclic AMP do normally?
Cyclic AMP is essentially the chemical brake that keeps platelets calm. So when that brake is removed, calcium just floods the platelet cytoplasm. This instantly induces activation.
Oh, wow.
Yeah, the platelet literally morphs from a smooth disc into this spiky, urchin-like shape, ready to grab onto anything it touches.
That is an incredibly fast, direct chemical switch. But what about cortisol? Because, I usually think of cortisol as a slower, longer-term stress hormone, not an immediate first responder like adrenaline.
Yeah.
How does a cortisol spike factor into this rapid blood draw scenario?
That's a great point. Cortisol acts through glucocorticoid receptors, and its effect on the vascular environment is heavily documented in the literature. If you look at human umbilical vein endothelial cells, so the cells that line the interior of blood vessels, treating them with hydrocortisone to simulate physiological stress, heavily increases the expression of a specific protein marker.
Which one?
It's called thrombospondin-1, or TSP1. And this expression peaks around 12 hours after the stressor.
Wait, really? So the stress hormone isn't just targeting the blood cells, it is actually changing the protein expression of the blood vessel walls themselves to make the environment stickier.
Exactly. And the causality there is undeniable. because when researchers pre-treat these endothelial cells with RU486, which is a potent glucocorticoid receptor blocker, the stress signal is completely intercepted.
Oh, so the increase in TSP1 is just star.
Completely stopped.
Yeah. Okay, so between the immediate hit of adrenaline ripping the brakes off the platelets and the sustained wave of cortisol changing the vessel walls, the blood is fully primed.
Fully primed. And this stress response enhances the expression of specific glycoproteins on the platelet surface. We see spikes in GPI, GPI-BI, and P-selectin.
Okay, wait, hold on. For those of us who aren't hematologists, let's break down that acronym in soup for a second. How do these specific markers actually function?
Right, sorry. Think of them as specialized cellular hardware that the platelet deploys when it gets stressed out. So, GPI acts as the primary hook. It grabs onto von Willebrand factor, which is a protein exposed whenever a blood vessel is damaged.
Okay, got it. The hook. What about the others?
GPI-BI acts more like a bridge. It binds to fibrinogen in the blood, which allows activated platelets to cross-link and stick to each other, forming the structural mesh of a clot.
And P-selectin.
P-selectin acts like a biological tether. When the platelet gets stressed and spits out the contents of its internal granules, P-selectin gets pushed to the cell surface. It specifically binds to white blood cells, or leukocytes, creating these clumps known as platelet leukocyte aggregates, or PLAs.
That paints such a vivid picture of the biological reality of an anxious patient before the needle even touches their skin, which, brings up a really important question about the baseline health of the person sitting in that chair.
Right.
Like, if I'm a totally healthy person getting a routine physical versus someone who has underlying cardiovascular disease, do our platelets react to that pre-draw anxiety in the exact same way?
Well, what's fascinating here is that the clinical data shows a critical divergence.
Really?
Yeah. In healthy subjects, if you introduce acute psychological stress, those platelet leukocyte aggregates absolutely spike. But the body has regulatory mechanisms, so the aggregates return to a normal baseline about 20 to 45 minutes after the stress session ends.
So the adrenaline clears, the cyclic AMP stabilizes, and the platelets disarm.
Exactly. But in patients with cardiovascular disease or CVD, those regulatory mechanisms are impaired.
Oh, man. So they don't disarm.
No, after an acute stressor, the percentage of these aggregates doesn't just stay high, it actually gradually increases for up to 75 minutes post-stress. The high adrenergic response in the acute phase of coronary syndromes actually predicts sustained, prolonged platelet activation. The platelets get angry, and they just lack the chemical signaling to calm back down.
That shifts the perspective entirely, because the biological stress is arming the platelets from the inside. But now we have to look at the physical environment of the clinic and the blood draw itself, because those act as massive external stressors.
The pre-analytical variables, right?
Exactly. This covers everything that happens before the lab technician actually places the sample into an analyzer machine. Because platelets are so aggressively reactive, clinical guidelines actually attempt to mitigate this biological observer effect.
How so? Like, what are the rules?
Well, guidelines dictate that patients really should rest for 5 to 10 minutes prior to venipuncture. The goal is to let the autonomic nervous system settle, minimizing that adrenergic stimulation and calcium flooding we just discussed.
And the physiological management goes way beyond just sitting quietly, doesn't it? Like, you have to avoid smoking for at least 30 minutes prior to a draw.
Yes, and the mechanism there is intense. Smoking increases platelet aggregability and decreases your fibrinolytic potential, meaning it makes your blood more prone to clotting and less able to break those clots down because of the PAI-1 protein, right?
Right, plasminogen activator inhibitor 1. Normally, your body uses tissue plasminogen activator, or TPA, to convert plasminogen into plasmin, which acts like molecular scissors to cut up fibrin clots.
But the PAI-1 blocks that.
Exactly. It binds to TPA and neutralizes it. So when smoking spikes your PAI-1 levels, it effectively cripples the body's natural enzymes that dissolve clots.
Wow.
You also have to avoid caffeine and physical exercise for 2 hours prior, because exercise increases leukocyte counts and induces a transient procoagulant state in the plasma.
Okay, I have to jump in here with some practical pushback, because if I think about my last blood draw, I definitely did not rest for 10 minutes.
Right, almost nobody does.
Yeah. They called my name, I walked back to the chair, and the phlebotomist immediately tied the tourniquet. And the equipment they use, every time I get blood drawn, they use those vacuum aspiration tubes because they're fast.
Vacutaners.
Right. They pop the tube onto the needle hub, and the negative pressure just violently sucks the blood out of the vein. Plus, they almost always use those little butterfly needles with the long plastic tubing.
So, are you saying standard clinical practice is actually stressing out the sample?
Oh, standard clinical practice is a constant compromise between clinical efficiency and cellular sensitivity. I mean, those vacuum tubes generate incredibly high negative pressure.
So it's bad for the cells.
When blood is ripped out of your vein and blasted through a narrow butterfly tube, the fluid dynamics create immense mechanical shear stress. For a platelet, shear stress physically yanks on those GPI receptors we talked about earlier.
Oh, wow.
The cell actually mechanotransduces that physical pulling into a chemical signal, tricking the platelet into thinking it's caught in the high-pressure turbulence of a severe arterial wound. It causes spurious artifactual hyperactivation.
So if the standard vacuum tube is traumatizing the cells, how are you actually supposed to draw the blood to get an accurate reading of platelet function? Well, for highly sensitive testing, the guidelines mandate a slow manual draw using a standard syringe.
Not a vacuum tube.
No. The phlebotomist manually pulls the plunger back at a controlled, gentle rate, which vastly lowers the shear stress and preserves the internal chemistry of the platelet. Furthermore, the passage of blood through butterfly tubing and high-V catheters causes significantly more hemostatic alterations compared to a conventional straight needle.
Because of the turbulence in the tube.
Exactly. And to ensure a smooth, low turbulence flow, that straight needle shouldn't be narrower than a 21 gauge.
A straight, relatively wide needle drawn slowly by hand. I mean, that is the complete opposite of the rapid-fire vacuum tube assembly line most of us experience.
It really is. And the protocol is even more stringent than that. You actually must discard the first few milliliters of drawn blood.
Wait, why?
Because when the metal needle physically pierces the skin and shears through the endothelial cells of the vein wall, those crushed cells release tissue factor into the bloodstream.
And tissue factor causes clotting.
Right. It binds to factor VII, completely bypassing the intrinsic clotting pathway and immediately kickstarting the extrinsic coagulation cascade. It generates thrombin almost instantly. So if you test that first tube of blood, you are measuring the biochemical artifact of the puncture wound, not the systemic health of the patient's blood.
I see. So if a doctor is just checking my basic cholesterol, maybe the vacuum tube and the butterfly needle are fine.
Sure, for basic chemistry panels, it's usually fine.
But if they are ordering specialized platelet function testing, like aggregometry or whole blood flow cytometry, these standard pre-analytical variables completely compromise the integrity of the test. You end up measuring the physical trauma of the blood draw itself.
Precisely. You are capturing the observer effect in real time.
Unbelievable. Okay, let's assume we managed to do everything perfectly. The patient rested, they didn't smoke, the phlebotomist used a straight 21-gauge needle, manually drew the blood with a syringe, and discarded the first tube containing the tissue factor.
The miracle draw.
Right. The blood has been drawn as gently as biologically possible. We're safe, right? The sample is pristine.
I wish. The biological stress is only half the battle. Now the sample is outside the body, isolated in an artificial plastic or glass tube, and the clock is ticking.
Because the platelets keep reacting?
Oh yeah, platelets adapt to their microenvironment incredibly fast. They are highly prone to in vitro activation, meaning activation happening in the glass on the lab bench.
It's literally a race against time. So when laboratories use flow cytometry, where they tag the cells with fluorescent antibodies and pass them through a laser beam to analyze the surface receptors, the speed of processing becomes the single most critical variable.
Exactly.
Like the sources show a 1.7% increase in platelet monocyte conjugate measurements of every single 10-minute delay between drawing the blood and stabilizing it.
Right, and temperature acts as an aggressive environmental stressor during this window too. If standard plasma tubes, the ones containing citrate, heparin, or EDTA anticoagulants, just sit at room temperature, the metabolic activity of the platelets doesn't just continue, it derails.
How bad is it?
Within just 30 minutes at room temperature, there is a massive 6 to 35-fold increase in the levels of PF4 and TSP1 released into the plasma.
Here's where it gets really interesting. A 35-fold explosion in activation markers just from a tube sitting on a lab counter for half an hour. I mean, that completely rewrites the patient's clinical story.
It raises a very important question about how we interpret lab results, doesn't it?
Absolutely, because if a delayed courier or a distracted tech leaves a tube on a warm bench, a doctor is going to see those astronomical levels and immediately think the patient is at imminent risk for a massive thrombotic event like a heart attack or a stroke.
Right, the handling error completely masks the true health status.
But practically speaking, if temperature causes this explosion, how do labs manage it? Why aren't phlebotomists just drawing blood inside refrigerated walk-in coolers?
Well, because refrigeration introduces its own cellular stress,
Yeah.
cold can actually activate platelets, too. The gold standard to stop the clot for flow cytometry is immediate chemical fixation.
Oh,
Right after the venipuncture, a chemical fixative, like 1% paraformaldehyde, is introduced directly to the sample.
how does the paraformaldehyde actually freeze the cells? Is it like poisoning them?
It acts on a structural level. Paraformaldehyde creates covalent bonds between proteins, forming methylene bridges that cross-link the amino groups.
So it freezes the structure?
Exactly. It essentially turns the fluid dynamic cell membrane into a rigid matrix. It locks the GPI, the P-selectin, and all the other surface receptors exactly as they were the second the blood left the vein, completely preventing spontaneous in vitro activation.
Okay, that solves the problem if you want to look at the whole intact cells. But what if the lab needs to test the plasma itself? Because to get pure plasma, you have to separate it from the red blood cells and the platelets,
Right.
which brings us to the final and perhaps most violent hurdle, the spin cycle.
Yes, centrifugation. Even if the clinic immediately stabilizes the sample and rushes it to the processing room, the standard method for isolating plasma introduces intense mechanical shear stress.
And this isn't just shaking a tube. The G-forces involved make it sound less like a washing machine and more like putting a delicate submarine through extreme pressure testing, where the structural integrity of the hull just buckles and the payload breaches out into the water.
That is exactly what happens. The physics are highly destructive to cellular integrity. A standard plasma preparation spin utilizes around 2,000 grams, that is, 2,000 times the force of gravity.
Wow.
This immense shear stress physically traumatizes the platelets, forcing them to irreversibly exocytose or violently spit out the contents of their internal alpha granules. We mentioned P-selectin earlier as a key activation marker. During centrifugation, it gets dumped directly into the plasma.
And the clinical data on this mechanical trauma is just staggering. There was a study from the University of Southern Denmark that tested this directly. They took citrate and EDTA plasma tubes and centrifuged them at 2,000 grams for 10 minutes.
Right.
And the result: 43% of the platelets in the citrate tube and 56% in the EDTA tube expressed P-selectin. More than half of the platelets were severely activated just by the mechanical force of the spin cycle.
Yeah, and this creates a fundamental paradox. If you were trying to measure specific proteins or markers that platelets normally store inside themselves, because the centrifuge just forced the platelets to dump all those internal molecules into the very plasma you were trying to test.
So the test is ruined before it begins.
Basically.
Okay.
To properly analyze certain plasma components without this massive artifactual interference, laboratories often have to utilize a double centrifugation process.
How does that work?
They spin it once, siphon off the plasma, and then spin that plasma a second time to drop the residual platelet count below the detection limit, which is less than 1 × 10⁹ per liter, and to aggressively purge the plasma of any trace of platelets just to get a clean reading.
But wait, if the first 2,000-gram spin already forced the platelets to dump their alpha granules, the activation markers are already dissolved into the plasma, right? Removing the empty platelet remnants in the second spin doesn't remove the chemical markers they left behind.
Exactly. And crucially, that same study noted a massive inter-individual variation in how platelets react to this spinning stress.
So it's not consistent.
No, it is not a uniform mathematical constant that you can just subtract out in a spreadsheet. One patient's platelets might survive the centrifuge relatively intact, while another patient's platelets completely degranulate. The mechanical stress alters every single person's sample in totally unpredictable ways.
So we have this violent pre-analytical process that essentially ruins the plasma. How do researchers get around this if they absolutely need pure, unactivated plasma?
This specific problem explains why researchers are actively utilizing pharmacological interventions just for the test tubes.
Wait, really?
Yeah. To protect the cells from the trauma of the laboratory centrifuge, they add drugs like prostaglandin E1 directly to the blood sample before spinning it.
What does that do?
Well, prostaglandin E1 works by artificially raising the intracellular levels of cyclic AMP, which, as we discussed earlier, acts as a powerful brake on platelet activation pathways.
Oh, I see.
It keeps the platelets chemically sedated so they can survive the mechanical trauma of the spin cycle without dumping their granules.
We literally have to drug the blood sample just to get an accurate reading of it. That is wild.
It really is.
So, synthesizing all of this, what does this all mean for the original question? We set out to uncover the effect of acute stress and high cortisol on platelet activation markers. The answer seems to be that measuring these markers is a fragile, multi-layered logistical nightmare.
If we connect this to the bigger picture, it begins with biological interference.
Mm.
Acute psychological anxiety about the needle triggers the HPA axis. Cortisol and adrenaline spike, dropping cyclic AMP, flooding the platelets with calcium, and physically altering their surface receptors to prepare for a wound.
And then the physical interference begins. The trauma of a vacuum tube violently ripping the blood through a narrow butterfly catheter, inducing mechanotransduction.
Right.
The exposure to tissue factor from the puncture wound, kickstarting the coagulation cascade. The ticking clock on the lab bench, where every 10 minutes of delay at room temperature causes an exponential spike in activation markers. And finally, the immense sheer stress of the centrifuge, forcing the platelets to irreversibly dump their contents into the plasma.
Every single step of the process conspires to falsely elevate the very markers we are trying to measure. Precision in laboratory medicine isn't just about having the most expensive analyzer machine. A state-of-the-art flow cytometer is completely useless if the sample it's reading was ruined by a delayed courier, a high-pressure vacuum tube, or just an anxious patient.
The key takeaways for you listening are clear. To get a true, unadulterated reading of platelet function, you need a relaxed patient with a normalized HPA axis who hasn't smoked or exercised. You need a straight 21-gauge needle, a slow manual draw into a syringe, and the discipline to discard the first few milliliters.
Exactly.
You need immediate chemical fixation with paraformaldehyde to freeze the cell membranes, and extremely careful standardized temperature and centrifugation management. It is a monumental challenge.
It really is. But bringing this back to the reality of the human being in the clinic, I want to leave you with a final thought to ponder. We've spent this entire deep dive analyzing how the transient 5-minute anxiety of a blood draw can physically alter the cellular behavior of our blood within minutes.
Right?
It changes our glycoproteins, our P-selectin, our leukocyte aggregates. It preps our vascular system for a fight that isn't coming.
The biological observer effect.
Precisely. So if a momentary spike in cortisol from seeing a needle can completely skew a sophisticated laboratory test by hyperactivating our platelets, how much of our everyday so-called normal physiological baseline is constantly being rewritten by the mundane psychological stressors of modern life?
Oh, wow, like traffic jams, work deadlines, financial stress.
Exactly. We go through life thinking our blood is just passively flowing along, but in reality, our cells are constantly reacting, shifting, and bracing for impact based entirely on our emotional state.
The stress we carry isn't just in our heads, it is fundamentally altering the microscopic reality flowing through our veins every single day. Stay curious, keep asking questions, and maybe take a few deep breaths the next time you find yourself sitting in that clinic waiting room. Thanks for listening.